Welcome to our MLAT 2021 clinical abstract on decision curve analysis, a tool to decide whether an early warning system model should be implemented. My name is Karandeep Singh. One of the biggest challenges when you're governing AI systems is to figure out, is an early warning system model good enough to use clinically? Let's talk about a sepsis model used in an early warning system. Let's assume that the area under the curve is something like 0.70 at whatever way you calculate it, however, the outcome of interest matters to you. And let's just assume that in the way that the model is trained, and then when you evaluate it in your data set, that the model slightly overpredicts risk based on a calibration curve. Is this model good enough to use? If you ask a machine learning researcher this question, what they'll likely tell you is that it depends on the context. And what they mean by that is that it depends on either the clinical situation, the observed performance at a selected threshold, or the performance measures at a selected sensitivity, for example, 90% sensitivity. And oftentimes, especially those second two bullet points, involve performance measures being shown to a clinician and getting the clinician's input. Do clinicians actually understand trade-offs in performance? I will submit to you that I think the answer is generally no. Here's an unscientific poll I conducted, asking physicians to choose a set of thresholds based on an observed sensitivity and specificity. And as you can see, I think the selections that people chose, all of these are completely illogical because they essentially correspond to an area under the curve of 0.50. So I don't think clinicians actually understand these kinds of threshold-based decisions the way you might think they do. Decision curves essentially take this logic and make the trade-offs explicit. So with decision curves, we actually can quantify a net benefit. And that net benefit depends on how many people are going to experience the outcome. The more common the outcome, the more benefit that can be achieved. It also depends on the costs and benefits of evaluating a patient in response to an alert, as well as the model performance that's observed at a range of thresholds selected based on the cost-benefit ratio. So essentially, the decision curve analysis can help you figure out if using a model is better than not using a model at all and evaluating no patients or evaluating all patients. So you can start off decision curves by basically asking a clinician this simple question: how many patients would you be willing to evaluate to capture one patient who will go on to develop sepsis? And then you can use that combined with the observed model performance to essentially back your way into a net benefit that can help you figure out if the model is good enough to use. I want to give a thank you to my co-authors, and there's more resources on decision curve analysis there. Feel free to email me. Thank you so much.